Have you ever wondered how artificial intelligence is helping solve medical problems? Or how medical research is making it easier to predict your genetic risks for disease? Hi, I'm Kathy Werzer. Tomorrow's Cure, a podcast from Mayo Clinic and PRX, is back for Season 2. Join me as I interview experts who are shaping the future of healthcare with groundbreaking advancements. What they describe may sound futuristic, but listen and you'll find out. Tomorrow's Cure is already here. Find it now wherever you get your podcasts.
I never quite understood #HotGirlIBS, but I am slightly worried about this trend.
This is On Nutrition, a podcast for Mayo Clinic where we dig into the latest nutrition trends and research to help you understand what's health and what's hype. I'm Tara Schmidt, a registered dietitian with Mayo Clinic in Rochester, Minnesota. This episode, poop. Nutrition focuses so much on what goes into our bodies, but what about what comes out? And you might be thinking, but poop is gross or inappropriate or immature. But if you never talk about it, how do you know if your body is working the way it should? So here to rectify our education about our rectum is Dr. Iris Wang, a gastroenterologist at Mayo Clinic in Rochester, Minnesota. Well, there are lots of technical terms for what she does, including researching gut-directed hypnotherapy. Dr. Wang could rightly be described as an expert on poop. Welcome, Dr. Wang. Thank you for hanging out with me this afternoon.
Thanks so much for having me.
I am so excited about this episode. I don't know if we're going to call it Everyone Poops or more formal like Everyone Has a Bowel Movement.
No.
I'm excited.
Please don't call it Everyone Has a Bowel.
Okay, the cooler title would be the title of your book, because you are a children's author of the book Boo Can't Poo, which I absolutely have in my home. My kids call it That Ghost That Can't Poop. So for those of you who don't know, Boo is a constipated ghost, and his family members give him excellent, clinical but fun rhyming advice about how to help him go poop.
I cannot tell you how meaningful it has been to hear stories of people's little ones who like Boo. And my favorite is this friend of a friend of a friend who is really mad because she wants to stop reading about the colon wall, but her toddler keeps finding the book wherever she hides it and asking for it to be read.
So cute. We love Boo in the Schmidt household. Tell me why you chose to write it, especially for a younger population.
It came out of a joke. I see so many adults, grown people with constipation, and we always go through how to treat their constipation, what are the right ways to poop, what are the things that can help. And more often than not, I hear this comment, how come nobody has told me about this before? And why am I 40, 50, 60, 70 years old when I'm first hearing about how to poop? And the problem is a lot of them are doing it wrong. And it's insane that our bodies can do this to us where we're supposed to be able to have this function and it just doesn't work. And so I would joke with them, I should write a book about this. I should write a children's book so that I can get people early so that they don't end up in the same boat that you're in. And then everyone would laugh and that's how I would exit the room. But then I was spending all this time reading to my toddler. And I thought, if you can teach quantum physics to a baby.
I have seen that book before.
I can do that for constipation.
I love it.
As I've been talking more and more about this book, I've realized how much of a taboo it is to talk about bowel movements. What do we call it? What's professional? What's normal? And I, somewhere along the way, have picked up the tagline that I'm breaking the poo taboo. And that should be the title of this show.
Done and done. I love it. As slightly uncomfortable as I used to be, dietitians talk a lot about poo, especially constipation and all of the things.
Yeah. You can't put things in if they're not going out, right? It's a tube. There's been studies that show constipation rates are so prevalent. There was one study that showed 37% of patients never brought up their bowel movement concerns to their physician. Right? People just don't feel comfortable talking about this.
But we have to talk about it. And like you said, it's a little taboo and we feel a little bit shy. I was someone in probably middle school and high school who tried to convince my ex-boyfriends that girls didn't poop.
That's a thing. Yes. And can we just normalize that, everybody farts, everybody poops. And these are not dirty words.
Exactly. So I get the super fun task today of asking you all of the questions that everyone else is too shy. And maybe that's karma for pretending like I didn't poop when I was younger.
You're doing great work.
Oh, thank you. I'm not blushing yet. What is the average frequency of bowel movements? Like, I think the common question, which I used to tell patients, like, it's different for everyone, right? Is what's normal? Like, okay, am I supposed to poop every day? If my husband does twice a day, like, is that concerning? What is our threshold of normal?
I think you are completely right in saying everybody's different. So there's some parameters that we all kind of use in a clinical and research setting to say this is normal or abnormal. So for diarrhea side, we say more than 3 bowel movements a day. Okay, we get a little concerned. And on the constipated side, less than 3 bowel movements a week, we call that constipation. But really, when I think about constipation clinically, I think, is it bothering you? And so do you feel like the stools are so hard that you're pushing and straining and having a hard time getting them out?
So how it feels is important. How do I know if it feels the way it's supposed to when we poop?
I ask my patients about what I call toilet yoga. It sounds better than positional changes. And if somebody's done them, they know exactly what I'm talking about, where they're kind of rocking back and forth on the toilet and kind of going side to side and trying to help that bowel movement along. I ask them if they have a sense of cleansing, right? When you get up after that bowel movement, do you feel like you've emptied? Because you can go 3 times a day and still not feel empty. And that's still constipation and not necessarily diarrhea, right? So that feeling and the experience is so important. And then when things get significantly worse, I ask if they need to ever do manual maneuvers, right? Using a finger, pushing on the pelvic floor. And when that's the case, they always look at me like, oh my God, how did you know I did that? And when it's not the case, they look at me and they're like, what's wrong with you? Why would you ask me that question? So I always preempt them and say, this is going to sound really weird if you don't do this. But those are the
questions. But if you do, I caught you and I know exactly what's wrong.
Exactly, right? And so I think within that parameter, it's really about how efficient is this bowel movement, how effective. Are you still bloated afterwards? Those are the things that we ask about and is more important to me clinically than the exact number of bowel movements you're having.
Are there any rules of thumb when it comes to color or consistency, right? Because that might depend also on your hydration status or what you ate recently. Any kind of concerns around that people are supposed to be looking for?
Really? No. And please just stop looking. I think it's always reasonable to look at your bowel movements, right? And I actually had a patient in clinic this morning tell me, I tried, but the toilet flushed so fast at the airport. But I think overall, when we think about color, I worry when it's blood and all spectrums of blood, which means if it is bright red and it's not a hemorrhoid or you're not sure if it's a hemorrhoid, if it is rusty maroon colored and continues to come, if it is black, tarry, kind of looking like melted rubber, those are things that we absolutely need to know about. We may not need to worry about it, but your doctor should know about it. Short of that, I would defer to you, Tara, as a dietitian, right? Why their poop looks like that color. It's probably the spinach, the beet, the whatever it was that they were eating in the healthful diet. Lucky Charms. Another thing that we see often is I can sometimes tell if people are drinking Gatorade with their bowel preps because the inside of their colon is still fluorescent, but that can influence a bowel movement's color and not really mean very much. And so unless it is looking like blood, the spectrum of kind of yellow to brown, we don't really worry about.
What are we looking for now with consistency of the poo?
There's a range. And what's normal for different people is different, right? And so still we go back to that symptom of complete evacuation and full emptying. There's a scale. It's called the Bristol Stool Scale for anybody who'd like to Google it or look it up. And you can print the scale and you can put it on whatever you like. I think it makes excellent bathroom decor, but what do I know? But anyways, the scale kind of ranges from what we call rabbit poops, which are very small pellets, all the way down to watery poops that are mostly liquid. And similar to kind of those guardrails around the frequency of bowel movements, we don't want you on either end of that spectrum. We don't want just little tiny hard pebbles because they're very difficult to pass. And we don't want just water. And we really don't want too much mush, right? We want stool to have form. And we want it to be easy to pass. And part of the reason we want it to have form is because that form of the bowel movement triggers the colon to empty, right? It tells your rectum there's something there so that it can more effectively get that bowel movement out. As opposed to something a little bit more liquid where it generates a little more cramping, a little bit more work on the part of your large intestine in order to expel that bowel movement. And often people feel incompletely evacuated. It doesn't feel as satisfying because it's just water coming out. And so we want to aim for form and we want to aim for not too hard. The best way to do that is to talk to your neighborhood dietitian.
Thank you.
About the fiber content, right? And we really want to hit a good consistency of fiber to water ratio to really get that optimized bowel movement.
Yeah, and this is where soluble and insoluble fiber come in, right? Like we need to have some kind of bulk, but we also don't want that bulk to be completely like dry and hard.
I'm actually going to, if you don't mind, ask you to kind of explain soluble versus insoluble fiber, because sometimes people say, okay, use fiber for diarrhea, but then you also use fiber for constipation.
Yes.
And I always have to reread the literature on which one is which and which one's good for what.
So soluble fiber is something that can absorb liquid. A good example of soluble fiber is like oatmeal, right?
Absolutely.
If you start with dried oats and you add less water than there is oats, and even sometimes more, they will soak up the water, and now you've got oatmeal. And so in the case of constipation, I want you to have more soluble fiber so that when you have, and you have to have excess fluid, right? You have to be hydrated so that there's excess fluid for your stool to pull into it, which will make it softer and easier for you to pass, versus sometimes when we want to, quote, bulk up someone's stool, we might need a little bit of insoluble fiber. But hey, psyllium husk, most people's friend, most people in terms of helping, probably with either.
I love that. And I think that's guideline recommended, right? All the GI societies love fiber. And it's one of the things that is recommended for everything.
Let's talk about footstools. Having something under your feet is super popular. People are saying that elevating your feet kind of straightens things out and makes it easier. Is that true?
There's a colleague of mine who's actually studying that.
Oh.
Of whether it actually does what it's supposed to do. And what it's supposed to do is straighten what's called the rectal angle. But we have this muscle structure called the pelvic floor in our bottoms. And women who have had babies often hear about their pelvic floors because that is what the kids sometimes damage.
This is why we can't jump on trampolines.
But you know that mostly from a bladder side, right?
Yes,
and you don't
right.
think about that from a bowel side. But actually, that pelvic floor muscle influences the rectum more than it does the bladder. And the reason is because there's a muscle that's dynamic in that pelvic floor. That's called the puborectalis muscle. And it almost acts like a sling around the rectum and pulls it into a narrow angle as we're all sitting here. So it's almost like a second layer of control for our anal sphincters, so that in case the anal sphincters are a little weak, you still have the puborectalis to keep things closed. And what we need to be able to do to effectively empty that colon is to straighten out that rectal angle by relaxing the puborectalis muscle. So it's like letting go of this pulley that's pulling the rectum up. The toileting stools, by putting your knees in that squatting position, what it's supposed to do is allow that puborectalis muscle to relax naturally. And so by allowing it to relax, it straightens the rectum and things can move downwards in a more efficient fashion. Does that work? I mean, that's the thing that we're going to tell, but I think anecdotally, a lot of people do experience benefit.
So what would you say is the right way to get in that position? Do you need one of those special footstools?
I always tell folks, you can use anything else you want. What you're trying to do is get the knees above the level of the belly button, but you want the knees open. And so if you are going to use a trash can in a hotel room, use two. Your knees should be apart, right? You don't put your feet on the same trash can because then it's kind of constricting things.
Or like 1 foot on the tub, 1 foot on your trash can.
I've got patients who turn themselves so that their both feet are on the bathtub and it works, right? For older individuals who have higher toilets, they have to buy higher stools.
Sure.
So that they can actually match that. For people who are taller as well, they have to think about what positions they're in. And then you want like a 30-degree forward lean. So you're kind of leaning forward, but your spine up straight. So that if you really want to do a phone, as long as your knees are up high enough, you can still put your elbows on your knees and like look at your phone. And that is why our husbands are in the bathrooms all the time.
Mm-hmm. So if you're wondering what's normal, well, there's a range. The clinical definition of diarrhea is more than 3 bowel movements per day, and constipation is fewer than 3 per week. But what's more important is how it feels. Do you feel like you've emptied? Was it painful? The good news is you don't have to worry about the color unless there's blood. Just make sure it's not the beets you ate the night before. In terms of consistency, we want poop to have form, but also be easy to pass. If it's too watery, insoluble fiber, like apples and beans, can give it some bulk. Hopefully this isn't gross, but think of something where you might see pieces of it in your stool, like bran, or if you eat a lot of blueberries, the skins of those. That adds volume to your stool and can help it if it's too liquidy. If it's too hard, soluble fiber, like bananas, grains, or psyllium, can help increase the moisture content. And while the scientific verdict might be out on toilet yoga, such as rocking back and forth or elevating your legs on a stool, most people feel like it helps them straighten that rectal angle and relax their muscles. But if only it were that easy. To be human is to have trouble pooping. So let's talk about those unfortunately common issues. Some people really never outgrow this fear or anxiousness of pooping in public.
Sure.
And so we hold it in until we're in the comfort of our home. Does that have an effect on the GI tract long term?
It's a really good question. The answer is I don't know. I don't think anybody has studied kind of childhood holding behaviors and eventual pelvic floor dysfunction. But I will say that stress and relaxation certainly are impactful to the pelvic floor muscles and to constipation in general from a number of ways. So when we talk about breathing and relaxing the pelvic floor, one of the things we want to think about is really activating our parasympathetic nervous system. And the way I like to talk about this is taking us back all the way to evolutionary biology. And when we were cavemen and women and we were running away from a lion, the last thing we need to do is pee or poo. Right? All the blood gets diverted to our eyes so we can see, our muscles so we can fight or run, and our brain so we can think. All the blood gets actually diverted away from our GI system, our bladder, etc.
Mm-hmm.
But in order to turn those systems back online, we need to be able to say, okay, stress is over. No more lion. We are now in the safety of our own home.
Cave.
And so we can then get rid of our housekeeping functions. But to your point, if we don't feel that safety at an outside bathroom, it's really hard to actually let go of those functions for that reason. And this is also why folks who are very stressed out when they travel, right? You've heard of all sorts of people who cannot poop when they're outside of their normal habit. And part of the reason is this sympathetic activation of stress. And so deep breathing can help us turn that off. It can help signal to our bodies that it is safe for us to turn on those housekeeping chores of emptying our bowels and bladders and allowing that to happen more naturally.
I was a kid who didn't poop at camp, right? I did not want to poop in the cabin. So I think I would literally just hold it for 7 days.
And then if you were able to stop doing that, it probably didn't cause any problems. But if you went to camp every month for years, then we would probably have a holding problem. Your body ends up learning to hold and forgetting how to let go.
Mm-hmm.
And that's when we really see the chronic constipation become a big problem.
And then is this the flip side? What about anxiety poops? Tell me more about this phrase.
This is an interesting topic because it's a very true thing. But I had to delve really deep into the science to figure out why some people can't stop their bowels and some people can't go. I don't think we have a good answer, but to the best of my ability, I can summarize it as we have different types of receptors to stress in our small intestine and in our colon. The stress receptors in our small intestines, when those get activated, and those are the predominant issues, speed up the small bowel. So you're more likely to get diarrhea and you're less likely to absorb things. The ones in the colon respond to stress by slowing down. So then depending on which one you fall in that balance, I think is the answer to which kind of anxious pooper you are.
Wow.
But this has not been rigorously studied. If somebody would like to fund this research, I am happy to conduct this trial.
So anxiety and stress can obviously mess up your ability to poop, but people who have long-term issues might also get some secondary stress and wonder if it's causing long-term damage. So is there a connection between, let's say, chronic constipation and chronic diseases like colon cancer?
I don't think it increases your risk of colon cancer. And nothing in the literature has shown that irritable bowel syndrome with constipation, for example, it does not increase your risk of colon cancer, which is good. Other things that may be associated with the development of both could be involved. So going back to fiber, for example, if you don't have enough fiber in your diet, you do risk developing constipation. And when you don't have enough fiber in the diet, often it's because the diet is a little bit more processed. It's a little bit more high in pro-inflammatory things like red meat, like alcohol, processed sugars, these Skittles I'm definitely not eating right now. But those things can increase your risk for colorectal cancer. So in that way, could there be an association? Yes. But we don't think that keeping stool in by itself increases that risk.
When we talk about things like IBS, constipation, how common are these?
So it depends on who you're asking and what data we're looking for and what criteria we use. When we look at all types of constipation, the estimated prevalence goes all the way up to 20%, depending on how we're surveying the population. The rates of IBS constipation was seen to be just about 1.5%. So not too much, but functional constipation, so that's constipation without any pain component, is like 12%. So I think a 10% estimate is a pretty safe bet. 1 in 10 people.
Wow, that's a pretty big slice of the population. So if you're one of those people, what's actually going on? What's wrong?
The problem is more in the movement of the bowels, where things are not going forward the way they're supposed to, or it's a diet problem where there's not enough fiber or not enough water to kind of help the stools remain soft. Often it's a pelvic floor problem. 1 in 3 have a problem with the pelvic floor driving their constipation. So I actually like to think about constipation as either primary or secondary. Primary being there's something wrong with the colon. So chronic idiopathic constipation can be that. IBS constipation can be that. Or secondary because it's being driven by or caused by some muscle in the pelvic floor not opening like it's supposed to, or some other hormonal physiology that's off. People who have electrolyte imbalances can get constipated. People with thyroid disorders get constipated. People with early onset dementia can get constipated. Other sorts of kind of rare conditions too can cause the colon and the small bowel not to move the way they're supposed to. And then between the two primary types of constipation, it really comes down to, is there pain out of proportion to a bowel movement, right? It's normal to get some cramping. But if that pain is really out of control, there's a component of your nervous system that's firing too easily and sending too loud of a signal up to the brain. That's irritable bowel syndrome constipation. Or is it just constipation where the stool's not coming out and it's uncomfortable because there's stool?
And this is why there are different types of laxatives, because some laxatives are going to force, I always say, like your colon wall to be stimulated and to move, whereas there are some laxatives who are a little more gentle and are just pulling water in. And a lot of times that's what I would steer them towards.
Absolutely.
We're just going to pull more water into your colon. I do not need to stimulate your colon to like get things moving. That probably functions, I hope, just fine.
And I actually have patients always start on that osmotic laxative first. That pull water in laxative is my backbone. And I tell them you take it like a vitamin because it's very safe too, right? Because what
like
it's doing.
Long-term safe. We have a lot of that.
Because it doesn't get absorbed. Its whole purpose is to sit in your stool. It's not supposed to go anywhere. And so it doesn't do anything except hold in water. And so that's why it's so safe for pregnant ladies, for women who are breastfeeding, and for children. You know,
I was going to say I had a toddler on good old Miralax for a good year of his life.
Absolutely, right? So safe. You cannot become addicted to it. Patients ask me a lot, actually, because the labels all say do not take for more than 14 days before talking to a doctor. And so they'll come in and they're like, well, I took the stuff over the counter. It worked great. And I was like, okay, so why are you still here? They said, well, I couldn't keep taking it because it said to see a doctor. And I'm like, oh,
Thank you
good,
for reading
good
the
reading.
label, though.
And the reason it says that is we want to make sure that your constipation is being worked up appropriately if you have risk factors, right? Because if you are of a certain age, above the age of 45 now, and you have never been constipated and all of a sudden develop it, we do need to do more workup. We do need to do a colonoscopy to make sure that it isn't a polyp, right? We got to work up those secondary conditions. And so that's why the labels say that. But once we've done a workup or just a brief review, either with GI or your primary care doctor, then those osmotic laxatives are so safe. And then I have folks do the stimulant laxatives as needed.
Okay.
So if it's been more than 3 days, then taking one of those at night is very, very helpful. For folks that are not keen on taking medications or are very sensitive to medications, one of them, Senna, comes in a tea that you can find in the tea aisle of the grocery store. And so I have people just drink the tea. And it's not as strong as taking a medication concentrated, but some people don't need that, right? And you just need a little push.
Yeah, that's super helpful. Speaking of when to see your doctor, we all, I feel like every millennial girl is like, I have anxiety and tummy trouble.
Yeah.
When should people be seeking out medical attention for a digestive issue?
I never quite understood #HotGirlIBS, but I am slightly worried about this trend. I want to encourage people to be able to talk about this, right? So if it needs to be like with your friends over brunch, then fine, just talk about it. When to talk to your doctor about it is if there was a sudden change, if you were one way and all of a sudden you are another way, it's worth mentioning to your primary care doctor if it's bothersome, right? So if you've gone from 2 bowel movements a day like clockwork, and now you're having 2 a week, it's reasonable to talk to your doctor about it. Our red flag signs are always if you're seeing blood in the bowel movements, you should talk to your doctor about it. And if you're losing weight that you cannot explain, then that's something to address with your physician.
Have you ever heard of the nocebo effect? Think about the opposite of a placebo. It's when you have a negative side effect simply because you expected something to happen. Now, that may not seem very straightforward, but the nocebo effect can have a huge impact on the outcome of a health event, like getting a new vaccine or having surgery. If your interest is piqued, check out The Nocebo Effect, published by Mayo Clinic Press, to learn more about how words can make us sick through medicine, history, culture, psychology, and philosophy. Get your copy today at mcpress.mayoclinic.org and use code HEALTHMATTERS, all one word, for 10% off your order.
So if you have constipation, you're not alone. 10 to 20% of people do as well, depending on how you're defining it and who you're asking. We don't fully know why it is that under stress, some people have a hard time getting poop out, and other people struggle to keep it in. But it may relate to stress receptors in the small intestine or colon, and which ones are being activated. And if all this information is stressing you out, don't worry. There doesn't appear to be a direct link between constipation and chronic disease, like colon cancer. When it comes to figuring out if a bowel issue is medically significant, a sudden change in your bowel patterns, blood in your stool, or unexplainable weight loss are all worth bringing it to your doctor. They can help you figure out an underlying cause so you can know what remedies will have the best results. To close things out, let's talk about food, fiber, and forms of treatment. Let's talk nutrition. We already talked a bit about how you might want soluble versus insoluble fiber depending on what you're dealing with, but we also want fiber as a regular part of our diet. From a bowel health standpoint, how much fiber should we be eating?
Interestingly, I looked into this recently. Not a lot of data-driven guidelines. I have a number that we always tell patients, but when I went back and tried to figure out why that number is that number, it's like a single paper from way long ago. So I usually say over 35 grams for a man and over 25 grams for a woman. And if you need to be in the middle, then just remember 30 grams and that's great. And I tell my folks to use something like a phone app to help them track at least for a few days how much fiber they're actually getting in, and to understand better what that breakdown is. And then I refer them to you to talk about it more.
Yeah, the other guideline I saw, which is from the Academy of Nutrition and Dietetics, is 14 grams of fiber for every 1,000 calories you eat. But again, I wouldn't only want someone to have 14 if they're only eating 1,200 calories. So that's a little bit skewed. But maybe if you eat 3,000 calories, maybe you need more than 35 or 38 if you're a grown male. So we just need to be more mindful of adding in plants into our diet and cutting back on ultra-processed foods that have absolutely no fiber in most cases.
Absolutely. Yep.
What would be the diagnoses or situations that we should not be having a high fiber diet? Because I hear that sometimes from patients. They say, like, I can't tolerate it, or I have IBS. I'm just not supposed to do that. Are there times when you would actually tell people to deprioritize fiber?
So one thing that you mentioned is the irritable bowel syndrome, where fiber just hurts. And because their bowels are so sensitive, it is really hard to tolerate fiber. But what I tell them is to not give up the fiber, but that we should talk about cooked soluble fiber and to try to maintain a healthy gut microbiome, right? Because that's something we need to think about, and to do what we can to slowly push that fiber content up. It means you do not eat a raw Brussels sprout salad. Like, it's going to hurt, right? And so me just telling a patient that is completely irresponsible. So I tell them applesauce, get a little bit of cooked fiber in there, and then we slowly move ourselves up. I do want to say that folks with pelvic floor dysfunction have trouble tolerating fiber. And that's something to think about if you are not tolerating fiber, or if there is a lot of that straining need for toilet yoga, you've had a lot of children. Those are all kind of signals to me that we need to look at the pelvic floor, because if you cannot get the bowel movement out, all the fiber is going to do is ferment. And so it's going to cause a lot of bloating and discomfort, because yes, it's holding in the bulk. But if the pelvic floor doesn't work well enough to get that bulk out, that's why patients have trouble and struggle with that increased fiber. So something for folks to note. The time when we really need to avoid is when patients have obstructions. And so if they've had any issues in the past that would cause kind of narrowing in their bowels, either temporarily or chronically, then they should really not be on that high fiber diet, because you don't want their bowels to be too slow or things to get hung up. They can try more soluble things. It's the roughage that we worry about. So those are good conversations to have on an individual basis with a dietitian who knows what they're talking about. And then, public service announcement. 5 days before your colonoscopy is the time not to prioritize a high fiber diet. I promise you I can see it.
Gosh.
And then we have to play guess the vegetable. Not that we ever do that in anybody's colonoscopy.
You're much too professional.
No, but it is kind of the time where the high fiber sticks around, because they're meant to do that. And it gets in the way of us getting a good, clean look at the colon wall. And we can't get rid of it because it's roughage. So please, please, please cut out the fiber for about 5 days before your colonoscopies.
I don't know how you can ever eat lunch at work. I just don't feel like I could stomach anything.
I think about my microbiome.
That's true. That's true. Are there foods that contribute to constipation? Or sometimes I will call them stool thickening foods in my dietitian voice.
Again, I think you're better to speak to this than I am, but I find the sugars, the ultra-processed foods, the white bread to be a little bit more constipating for individuals. And on the flip side to that, protein powders and supplements are notorious for being constipating. So like that whey protein that bodybuilders will use, don't ask me how I know, maybe personal experience, but it will constipate you.
Would we have someone who actually wants to thicken their stool, so they're intentionally trying to get a little bit more bulk? We would say things like peanut butter, banana. So like I'm just like tell toddlers or parents of toddlers who have a little bit of softer stools, like give them a piece of toast with peanut butter or banana on it, and that might thicken things up. Cheese is actually pretty thickening.
Yes.
Pasta. And then on the flip side, I usually start with like pea foods, right? So like what foods help to get things moving. So I should talk about like pears, prunes, and peaches. What's on your list?
Kiwi fruit is on my list because it was a big study that came out a couple of
really?
years ago. 2 kiwi fruit a day are the equivalent of Metamucil. and
Nice.
supplementing, and 4 prunes. So 4 prunes or 2 kiwis with the skin off is good enough fiber content to be a fiber supplement or be equivalent to a fiber supplement. So I add that. Mangoes are really nice. Pears I use a lot too.
Let's talk about traveler's diarrhea. What is the cause? And is there a common cause? I always think it's water. How can people stop it if you're like on a lovely vacation and would like to not spend it in the bathroom?
So most of it is bacterial. So some sort of bacterial exposure, whether that's in the water or on food that hasn't been cleanly processed. If it's coming from water, sometimes it's Giardia, which is a parasitic infection. Most of our body should be able to clear that on our own. And so we don't need to necessarily worry about antibiotics. But the thing that we suggest is actually bismuth, subsalicylate or Pepto-Bismol has a really nice ability to stop bacteria from growing. So it's called bacteriostatic and also has the ability to kind of slow down the bowels.
Oh,
so nice
the
to keep some
tabs
Pepto
work?
on hand.
Can I do like the tabs, not the...
Should be able to. But if you have like a fever, dysentery where there's blood coming out, then maybe take an antibiotic or see a doctor first before you take an antibiotic. Because sometimes the antibiotic does more harm than good.
Yeah.
But you'll be safe with bismuth.
I think from what I see, a few more non-traditional or less traditional treatments are kind of coming about when we talk about GI distress or diagnoses. So let's talk about kind of what they are and when they're necessary or appropriate. Everyone's favorite, enemas.
So enemas people get nervous about, but they can be really good tools in a constipation toolkit, okay? And where they're helpful is when you haven't gone to the bathroom for so long that the stool at the bottom is so firm and impacted that it just hurts to come out, right? And if you've been constipated, you know what I'm talking about. Enemas are the right way to go in that situation because if you just keep putting meds from above or even stimulant laxative, it's going to hurt because there's actually now an obstruction. So what you really want is to go from below and ease that obstruction and break things up. What do you use? There's small enemas over the counter that can be used, but tap water works as well as anything else. Mineral oil can be really helpful as well, which softens up the stool. I know you're making this face.
I know, sorry.
But
you can't see my face, but I'm cringing right now.
You're about to cringe harder. So mineral oil helps by breaking up that kind of firmer stool. And I always like to share the Southern Grandma special because I trained a little bit in the South, which is a milk and molasses enema. And you can get it in the hospital. The kitchen has to make it. They don't like you very much.
No
and
way.
Everyone's very confused, but it works because it both softens and also stimulates the colon to go. Milk and molasses.
Okay, less controversial. Mindfulness.
We talked a little bit about that parasympathetic nervous system, right? And how it's really important for our bodies to know that it is a safe time to poo. There are no more lions around. And that's really what mindfulness is trying to achieve, is that re-regulation of our parasympathetic nervous system. The other aspect of it is kind of breathing techniques, pelvic floor muscle retraining. All of those things can help our muscles move the way that they're supposed to. And doing that can kind of help our colons regulate as well. So really very, very helpful, very low risk, very accessible, but you do have to commit to the time to doing it.
And is that in the same family as biofeedback?
It actually isn't. So biofeedback is more based on muscle therapy. So mindfulness retrains your central nervous system and your nervous system connections. But biofeedback actually teaches you how to control muscles. So when we talked about the pupil rectalis muscle and how it does not relax, right, when it's supposed to. Yes, you can get a toileting stool to help that position, but you can also learn what it feels like to take control of that muscle and teach it to relax. So I kind of liken it to telling people, yes, you can breathe without thinking about it, right? Your upper diaphragm moves. But if you do need to pause and take that deep breath, you can mentally think, okay, I'm going to pause, I'm going to take a deep breath. And you're moving that diaphragm, you're taking over that control.
Cool. Last one, gut hypnotherapy.
So topic near and dear to my heart because I do hypnosis for my patients and I offer gut-directed hypnotherapy and I have a research program in it as well. And that's sort of an extension of that mindfulness, right? Is if you need more help guiding the connection to normalize between your brain and your gut, if that pain signal is just way too strong and you need more help to turn down that signal, then hypnotherapy is actually really fantastic for that target. And what we do is we put you in a state called a trance state. And it is not like stage hypnosis. Nobody clucks like a chicken. Nobody's spinning
Takes
round
their
and round and
clothes
tapping
off.
their head, right? Like, I don't need that in my life or yours. But more, we're kind of getting you into this frame of mind, right? And we've actually done EEG studies, functional MRIs to show that the brain waves actually change when you enter hypnosis trance. And it's very different than meditation. It's a completely different brain state. But you're more susceptible to suggestion, so that I can suggest that your bowels are going to be okay and they actually heal. Because a lot of this is this hypervigilance and increased awareness of your bowel symptoms that aren't helpful to anyone. There is no IBD, there is no ulcer, but your body keeps telling you that there is. And so hypnotherapy allows us to use your own mind to tell your body that it's okay to heal. It works best after we've done that workup and proven to you that there is no ulcer, right? But then even sometimes when we do that, because the pain is real, the pain is happening, it's hard for folks to turn that pain down by themselves. And hypnosis can be a really fantastic way to do that.
You are so cool. You're absolutely magical.
Thank you.
Dr. Wang, you are amazing. Thank you for all of your uncringy, non-embarrassing expertise on poop.
Thank you so much for having me. You are too kind and allowing me to nerd out about my favorite bowel regulating tips and tricks.
When it comes to having healthy bowels, fiber is your friend. A good fiber target is 25 grams per day if you have a female body and 35 grams per day if you have a male one. If you have trouble tolerating fiber, like you have IBS, pelvic floor dysfunction, or bowel obstructions, you shouldn't cut out fiber altogether, but proceed with caution and see what you can tolerate. If you want more fiber, fruits like pears, prunes, peaches, kiwi, and mango are all great and tasty sources. And if, on the other hand, you need to thicken your stool, peanut butter, bananas, cheese, and pasta can do the trick. When it comes to treating constipation and other bowel disorders, enemas, mindfulness, biofeedback, and hypnotherapy are all tools you can consider trying. Your doctor can help you figure out what's the best fit for your gut. That's all for this episode, but if you've got a question or topic suggestion, you can leave us a voicemail at 507-538-6272. We might even feature your voice on the show. For more On Nutrition episodes and resources, check us out online at mayoclinic.org/onnutrition. And if you found the show helpful, please subscribe and make sure to rate and review us on your podcast app. It really helps others find our show. Thanks for listening, and until next time, eat well and be well.
Have you ever wondered how artificial intelligence is helping solve medical problems, or how medical research is making it easier to predict your genetic risks for disease? Hi, I'm Kathy Wurzer. Tomorrow's Cure, a podcast from Mayo Clinic and PRX, is back for Season 2. Join me as I interview experts who are shaping the future of healthcare with groundbreaking advancements. What they describe may sound futuristic, but listen and you'll find out. Tomorrow's Cure is already here. Find it now wherever you get your podcasts.
This podcast is for informational purposes only and should not be relied upon as medical or legal advice. Always consult with a qualified healthcare provider for any medical questions. The appearance of any guest does not imply an endorsement of them, their employer, or any entity they represent. The views and opinions are those of the speakers and do not necessarily reflect the views of Mayo Clinic. Reference to any product, service, or entity does not constitute an endorsement of or recommendation by Mayo Clinic.